But recently I've been wearing a different scarf, working around economic development and the kind of economic determinants around how decisions made in business forums, decisions made on the, as you mentioned about licensing and the kind of food outlets and things that we have. And one of the things that's really interesting when I've spoken to business leaders is they've said, why don't you involve us in the conversation sooner? Because actually we are interested in this stuff. And I think what we kind of traditionally tend to focus on is, are they a health related business in the private sector? But actually, if you speak to colleagues we went on a site visit to a manufacturing firm in Rotherham, and they were putting so many brilliant initiatives around mental health, physical health, walking to work, cycling, to all these kind of initiatives for their workforce. They were a million miles away from the healthcare sector, but actually their priority was around the well-being of their workforce. So I think there's something in there about us widening the conversation and who we think should be around the table, and not just, I'm not saying that we're assuming, but we kind of tend to accept the people that are there, or we've got these touch points, but I think sometimes we need to push beyond those boundaries as well.
Yeah, thanks, David. I haven't got a solution, but you've certainly made me think, and particularly from a mental health perspective, we tend to have relatively long-term relationships with people using our services. So I'll be really interested in working with you and partners and thinking, actually, how can we use that relationship to I guess, to respond to what you're asking us to do.
Thanks, Piers. David, in answer to your question, do we find these reports helpful? Yes, I do. I guess where I do struggle, though, slightly is if you think about the Sheffield model community, and if we think about the correlation between cancer prevalence, mental health need, diabetes, and those sort of, to some extent, lifestyle-related issues, where I struggle slightly is to go, where do we next need to foster the next bit of community asset building in the South Yorkshire population to try and address those things? So just working through the disease prevalence bit on that axis, through our communities on that axis, where do we need to go to next, and what does that mean about a differential approach to community asset building, and which community comes next? It links a bit into Shafiq's and other points, really. So I do find the reports useful, but they leave me slightly with a, oh crikey, this problem's slightly oceanic. Which bit do we need to go and boil slightly? But that might be overly simplistic.
I wouldn't. So I wouldn't worry too much, Lee, because the team don't have the resource to go everywhere. So it tends to, we've got an AIM tool that we've developed, so we know the communities. So actually our core work is focusing on the areas that most need it. So I don't think we need to kind of do anything extra on that. I mean, I guess additional resources is always helpful to widen that. Interesting thing in the report is that if you look at GP practices and meeting the care standards, once again, we kind of buck the trend. It's not all the deprived communities you think who might not get the care standards. There's some really innovative practice within GP practices within quite deprived areas who are actually doing the best. And the other bit of that will interest you is the practice with the highest spend on diabetes doesn't have the best outcomes. So there's actually some practices who have quite moderate sums of money paid into medicines, but actually have really good outcomes. So it doesn't always follow what you would expect. So I think what we need to do is, there's a huge amount of work of tackling variation, because we have a huge variation of provision there. But I wouldn't be too worried, because actually population health is about us doing the right things as core work, not seeing it as something extra we need to focus on.
Yeah, thank you. I think David's probably said most of what I was going to say, but I do think it's important to reflect on where those pockets of really best practice are and what makes those different, because they're probably not spending a lot more money, or they might be spending less money, but they're doing something qualitatively different, and we need to look at that more. But then my second point was going to be about something similar in a way, which is It's not about creating new stuff. This, Shafiq's already said it. There are opportunities to work with people who are already working in communities, and it's how we focus ourselves on that. And that might be just little bits of money. Shahida and I were having a conversation in Rotherham a couple of weeks ago about a community health day, and a little bit of support to that organisation that already wants to do that work. So I think it's about those things, and it's not necessarily about lots and lots of money. It is about how we use that money that counts.
Leslie, thank you. David, I think the answer to that is it really is valuable to have these reports. And they both reinforce the issue of health inequality as well as picking out individual diseases. And so actually really valuable, and I found that discussion helpful. Thank you. Can we move on to agenda item 12? Lee, system planning, operational financial plan first, and then we'll go on to specialist commissioning. Lee.
Thanks, Chair. So, as already trailed elsewhere in the meeting, money is tough around here, not just in South Yorkshire, but more generally in the English NHS. So, if we look at our month 4 financial performance as an ICB, we've got a deficit of 23.3 million, which is 8.6 million negative plan. You'll remember from the Chief Exec's comment, where we need to be is the ICB breaking even to deliver our £49 million deficit as a system, which means all that we can afford is the providers generating a £49 million deficit. So we are behind plan as an ICB. Often our savings are backloaded as we sort of generate savings. So first half of the year tends to be slightly worse in terms of financial performance than the second half of the year, but there's lots to do to get us there as an ICB. In terms of the system, including our 7 hosted statutory providers within the NHS, we've got a total deficit position of 55.9 million. So we're already over the year end total. So one of the reasons why we've been selected at month 2 for the investigation and intervention regime is for NHS England to give us some assistance, say, well, what are we going to have to do then to try and get us back on plan and to get to that £49 million deficit number? We've already got a lot of efficiencies built into the plan. So 255 million, 115 million at the ICB, 140 million for providers. The ICB position also includes this sort of stretch CIP, which is phased in the second half of the year. So we need to find more schemes and initiatives to deliver our plan in the second half of the year. The work that we're doing at the moment with NHS England and with Deloitte, who we'd already commissioned to do some work prior to the I&I process, is looking at what can we do to heighten our financial control environment safely in terms of delivering further savings. And it's also critically appraising our extant cost improvement plans to go, where else might we look? So we've landed one of those reports already. The second one on the drivers of the deficit, where we might look for the CIP, will land this week. And there's quite heavy engagement, as you might imagine, in the chief exec and finance community in the system to go, what are we going to do then in terms of delivering the savings safely? So lots of work going on in the finance space prior to the arrival of the I&I regime and elsewhere. One crumb of comfort in the month 4 position, single swallow doesn't make a summer, however, is the month 4 position, there wasn't much of a deterioration based on month 3. So if you think about what triggered the I&I process in terms of month 2, the actual month 4 position as a single month, single swallow doesn't make a summer, however, wasn't as bad as all that. So we're awaiting with interest the month 5 position, which we're putting together now, and we'll see what that starts to look like. But there's engagement both with NHS England at a regional and national level to go, what are you going to have to do to get back on plan then? Some of the Deloitte's work will help with that. The next big piece of work we're doing is looking at that sort of 49 million stretch CIP number, and what are we going to have to do to sort of book against that? And we've got some outline plans for that, which we'll discuss in the first instance. Well, not quite the first instance, but we'll discuss again with Chief Exec colleagues at 5 this evening. Happy to pause there, Chair, and take some questions.
Yeah, and clearly there's a lot more detail and some more information which we'll be doing in the part 2 session, the private session. But any questions for Lee at the moment? I mean, I guess 2 things I'd say. One is I've been in conversations with chairs, individually and collectively, and there's a risk that this becomes obsessive. It's the only thing we talk about, but critically, the message we are getting centrally is there is no more money this year. So this just does feel like we've got to get there and deliver it. But equally conscious of the other conversations we've already had today and how do we strike the appropriate balance. That's the board's job. And we'll have a discussion in part 2 a bit about that. Any questions for Lee on that? Specialised commissioning, Lee, are you going to pick us through that?
Yes, Chair, and thank you. To note, there has been a proposal for a number of years now about the delegation of additional services to ICB level from NHS England. And Appendix 1 shows you a long list of services that we are about to take on, highly likely to take on responsibility for commissioning from the 1st of April 2025. So what's 3 out of the 8 regional English footprints have already received these delegations. So the Midlands bit of the NHS is currently, the ICBs are commissioning these services already. We made a decision as North East and Yorkshire and the 4 ICBs that we weren't quite ready to do this yet in terms of the complexity of things going on. There is now lots of active work going on between NHS England as a regional team and the specialist commissioning team for these services, and the 4 ICBs to go, how will we land this delegation safely? I would claim it's a slightly different set of delegations to pharmacy, optometry and dentistry, i.e. the providers that hugely predominantly deliver these services are already known to us. There are incumbent sort of NHS providers, more or less. So what we're doing is we're sort of changing the way the money's routed from the regional tier to the 4 ICBs. The current proposal is we have a committee in common that commissions these services that we will host in South Yorkshire on behalf of the 4 ICBs. And there's a lot of staff work going on at the moment to get to a positive decision, we hope, with the NHS England board in December, who will make a decision about, are we ready to receive these services? The report outlines the work underway, that there's the 3 things I'd highlight at the moment that we're sort of working through is, what's the model for the management of the retained services for NHS England? And what does that mean about the staff transferring to us? So that's quite a live debate. There's a very live debate about the commissioning common structure and what that starts to look like and how does that operate. And there's a huge, big conversation going on just about the organisational development work to support this. So if we're genuinely trying to commission these services differently, with the inclusion of our incumbent providers, as opposed to a bit more of a sort of purchaser provider split, us and them, what does that start to look like in terms of engagement? So this paper's here as a board update to say this thing is coming. I think what's recommended in the paper is the way in which we made the decision on pod was to do a sort of meeting with assurance committee chairs and kind of go, are we ready to receive this, yes or no, which might be the same model because there's a quality dimension to this, there's a people dimension to this, there's a finance dimension to this. So is that the right model? And it's just to update on the very active executive staff work that I'm leading on behalf of South Yorkshire ICB with the 4 ICBs and specialist commissioning. There's 3 workshops planned, one on Friday, one next month and one the month after, which really gets into the nitty gritty. I'm not allowed to use that expression anymore, which really gets into the detail, of how we're going to do this work, both in terms of the December NHS England delegated decision and then the work that flows beyond it. I think I've probably said enough. But happy to take some questions.
Couple of questions. Could you just remind us of the scale of this, the money that we're talking about?
It differs based on the hosted spend versus the population spend. So we're currently running that to ground peers. I knew that question would inevitably come up and I was trying to include it, but there's 2 slightly different views based on hosted spend and the population spend. It's more material in terms of financial flows than pod, but I haven't got the sort of to the nearest 10 million estimate. Self-evidently, we're going to have to understand that before it's delegated.
Kathy, and then
Yeah, and thanks, because I probably would have picked some of this up if I'd not been on leave. But I suppose for me, there's just kind of that anxiety in relation to the pace that we did with pod delegation and not really truly understanding some of the intricacies around quality and safety oversight, what was in place, due diligence that sat alongside that, and that kind of difference between what we delegated to us and what we might host for the rest of the region. So I know I've got people in my team kind of involved in that space, but I do have anxieties about that, and I just kind of wanted that noted really.
Yeah, very, very similar point. I acknowledge Lee's point though that you know, we're going in with our eyes more open, I think, in this delegation than what we were. My learning from this process from the pod delegation needs absolute openness and transparency with NHS England, with a rigor that comes with a delegation, and that's not to underestimate the amount of capacity that needs to go into that, because it is substantial. So we need to be aware of that, given our changes to the target operating model. The second thing is, it's never all sorted on day one, and I think that's what you're alluding to, Kathy, is that as you get into this sort of thing, you do realise, oh, that's something we didn't think of, or that's something that wasn't sorted on day one. So again, what is our capacity back at the ICB to do true transformation, which is what we're really talking about for the benefits of here. But to end on a positive, and I would say this, wouldn't I think we are seeing the benefits of the ICB taking on the commissioning responsibility of POD. I do hear from our providers and our stakeholders that we're much more engaged with them as from the previous setup, and that's got to be our ambition, hasn't it, through this. So same point as Kathy, just a little bit of a sort of, let's go in with our eyes wide open and not underestimate the amount of capacity, but if we need it, but if we get it right, it really can work.
Kevin, you've put your hand up. I'm sorry, I think I might have missed you before. I apologise if I did.
Not to worry, I'll get a second bite of the apple later on in the agenda, Chair. But I for my sins, I'm the non-exec who sits on the specialised commissioning group covering most of the north and east region, and I think it feels, in many ways, it does feel quite different to the primary care delegation, because I think we've had lots of exposure to the issues that we are dealing with, and as Lee said, I think it's an issue about being very clear about how we address them. So it does feel a little bit different about our pre-engagement in the issue, maybe, but that's just, as speaking as non-exec on that committee. But I guess the question is, at the moment, is are we clear as we speak what are the key risks to delegation that we absolutely need to nail down before it becomes safe?
Lee, do you want to answer that?
I think so, yes, Kevin. So I from my perspective, the reason why I talk about the retained service model is that there's one view of the world, which is there's currently a regional team discharging the responsibility for this work, which will transfer directly into the committee in common structure in some way, shape or form. However, but self-evidently at the moment, they're doing elements of the work to deal with the sort of retained NHS England services. So the reason why I put that sort of front and centre in my update is that's the bit that we really need to understand when we meet in the workshop on Friday, to kind of go, to be honest, if it transfers with the incumbent NHS England staff who are currently doing this commissioning responsibility into the commission, the committee in common structure hosted by South Yorkshire, it feels like there's loads of work to do, self-evidently, but quite a safe transfer. But I don't know what subsets of those individuals, candidly, are going to be required for the retained model. That isn't to say there are other risks, but the bit that we're particularly tracking down at the moment is how does that retained NHS England commissioning portfolio post-transfer for the 8 English regions, how does that work then? Because if that demands a lot of time from the incumbent team and we don't understand that, we've self-evidently got a resource gap for the level transfer before we get into how do we want to think about commissioning things differently, linking it to our mainstream ICB commissioning portfolio and engaging with providers differently. So it's not a risk-free zone, but the reason why I put what's the retained service model there front and centre in terms of the first risk to manage is I don't know, we don't quite know what subsets the incumbent team we're getting until that's resolved.
Thanks, Lee.
Will?
Yeah, just a couple of things. Just a couple of things. Thanks, Pierce. I'm trying to think about the sort of the positive bits of this as well, what the opportunities might be. But I guess one of the risks will be that historically the requirement for increased finances has been quite predominant in this sector, hasn't it? Just thinking, you asked the question around what we spend on specialised services. I think nationally it's about 90% of the total NHS budget for mission services. So you could probably translate that locally. But there is something about thinking about the discussion we've had around prevention here today, not to lose that same focus here, because the opportunity that there is to bring the discussion locally and the commissioning responsibility locally is to be able to think about that across the whole pathway. One of the other things that needs to be considered, I think, Lee, and it might be being picked up in the focus of the delegation, is the fact that locally we are working in a very integrated way with all of our partners. And I think there's a recognition that because these are big commissions really on a national footprint, the approach to integration is probably not quite where we are locally. And I think that is material in terms of the delegation, because I think the quicker that we can align those two approaches, the more chance we've got about being able to make some of the fundamental change that we might need to make, and that sort of left shift from a specialised into non-specialised, but also into non-acute, non-hospital pathways as well.
Thank you. Did you want to come back on that?
If I can, yeah, there are absolutely opportunities here. Just one specific example, but there are a number. If the post delegation we hold the budget for end stage renal failure, it's a lot easier then to see how would we move the money around about what we might do about acute kidney injury and trying to minimise our end stage renal failure population. So you can see a number of examples where you go, if we had a commissioning budget which was a bit more pathway end to end, you could start to think about how would you engage with clinical staff, as and all renal physicians would be very keen to do this, about what we do about AKI, acute kidney injury, to try and avoid people finishing up in dialysis, and engaging very fully in that conversation. One of the critical challenges with the delegation, to be honest, is do the 4 ICBs in NEY have a similar view of how we want this integrated model to work? And I have quite a high degree of sympathy with NHS England, really, about if they're trying to sort of deliver a delegation process with 4 quite dissenting views of how this integration might work across the 4 NEY ICBs, that is quite challenging. So one of the challenges for us is going, how do we keep reasonably in step as 4 ICBs about pace of change, how we want to do things differently, noting that there's elements of it's not broken, so we don't need to fix it, but we could do things differently. But we've almost got to emerge an approach, haven't we, that keeps the 4 ICBs in North East Yorkshire in step. Otherwise, it becomes an impossible task for NHS England about, well, you're asking me to delegate it in very different ways, which is singularly unhelpful. Now, there's scope for change, but one of the main things we need to agree is what's the pace of some of that change? And have we got a consensus across the 4 ICBs in NEY about that this seems like a sensible pace of change and things to prioritise? Thanks, Will. Sorry for the length of my response, Piers.
Yeah, of course. Thanks, Chair. And it is just a very brief clarification that in terms of the work today, and from an executive and also from an independent non-executive perspective, Lee set all that out. The paper does set out an expectation and a request from the board to convene a meeting of the Assurance Committee chairs, which we'll set up, transact. I did just want to highlight and just make clear that the board it is a decision that will be reserved to the board, so it will come back to the board once all of that assurance piece has been completed to ultimately make that decision to go ahead.
Thank you. Really helpful. Let me just say a couple of things. I actually agree with Anthony here. Look, we all know that this is going to be difficult as it gets devolved, but if we want to shape services differently, you take the responsibility, you take some of that to say, and what would that mean for our residents in South Yorkshire? Actually, this is a big opportunity. The opportunity might not come for a couple of years because we're having a year of stability, but actually it feels to me that as an ICB, we can't sit here and say, we want to do things differently, we want to spend our money differently, say, but this is a difficult problem, we don't want it. This is what we should be doing. We want assurance, we want to do it properly, we want to have stability, but we want to reshape services for our population because that's what we set out we wanted to do. So when it comes to that decision, this is a real opportunity rather than, oh, it's very difficult. Well, of course it's difficult. Most of the opportunities are. So I think it's really good work. Helpful to bring the committee chairs together. Recognise it comes back here. Kevin, you wanted to come in.
Just linked to the committee chairs coming together, Chairman, can we, as part of that discussion, have a very clear exposition of the risks and benefits of South Yorkshire hosting this arrangement, if I've understood it properly, because I'm not clear of the benefits, and just listening to Lee about potentially herding a number of ICBs, it might have a number of inherent challenges. So it'd just be helpful to understand the basis of the thinking around South Yorkshire being a host. Thank you.
Yeah, we'll make sure that happens. Thank you, Lee. Thank you. That was a helpful discussion. Right, we move on to the next agenda item, which is integrated performance report. Who's take?
So I'm the kind of headlines and then invite individual colleagues to comment on their sections. But Sarah, do you want to give us a kind of overview?
Yeah, thanks, Gavin, and thanks, Pierce. So you have got another version of the integrated performance report. I hope you noticed some of the stuff we've been talking about in terms of the deprivation there linked to A&E and waiting list, which is absolutely where we need to be in terms of linking the earlier part of the conversation with actually the hard metrics in terms of what we've got to produce. I'll take the operational ones, then I'll invite Christine and David and Kathy to pick up the other areas of the report. In terms of operational delivery, if I start with the AD performance, you will have seen the slight deterioration in June. We have seen, though, an uptick in performance in our August position by a couple of percent. We've still got about 4% to improve to meet the national standard. Load of work going on at place levels, lots of work in urgent care boards, big focus around winter, which is coming at a rate of knots because we haven't closed our winter beds from last year. Oh, excuse me. So we haven't closed our winter beds from last year. So a big focus around that. I think my biggest concern in the ED and the emergency performance is around our ambulances and our ambulance handovers and the long delays we see in Northern General and in Doncaster. There is additional monies being funded into ambulance around patient flow coordinators into those departments to help us stream and move patients to the right place. Difficult conversation going to come up in our urgent care board in the next month, the next week, is around our zero tolerance and what are we saying is our standard for South Yorkshire. We had our pre-meet this morning. London have gone for a 45-minute tolerance to say that actually if a patient isn't handed over within 45 minutes, if it's safe to do so, then the ambulance department leave because it's more important to get those ambulances back on the road. So we're going to have that difficult conversation. We started it with hospitals yesterday and that will continue over the next couple of weeks. We need to resolve that going into winter. So big piece of focus around that. Other risk around AD performance is obviously Sheffield are going live with their EPR in October, which again, we've seen some mitigations and plans. Ian and I had a conversation with the team earlier in the week, but we need to make sure that that is robust in terms of how we're going to implement that system. In terms of cancer and cancer performance, you've seen that there is an improvement in terms of our faster diagnosis standard, and we're now meeting the national standards. Again, that's really good and really progressive in terms of the work we've done around our pathways around dermatology and skin cancer. What we are now doing is letting people know quicker who haven't got cancer. The issue is now for actually, if you look at it, that translates into the 62-day target where we're only delivering 50% of the standard in our Sheffield hospitals, which is why it is in a tier 1 service and we're meeting fortnightly with NHS. We have received in the region of an additional £1 million into supporting us to deliver improvements. Actually, we're struggling to spend it because a lot of it is around workforce and workforce restrict. We can't get the clinicians for the work that we need. But there is, again, some work going on because some of it is around our urology pathways and access to theatres. Breast, we've seen, and we are a national outlier now in terms of how long patients are waiting for breast surgery. We've seen we are going to spend some money looking at additional lists at weekends to clear through that backlog. And Sheffield are doing a piece of work reprioritising their theatre capacity to target for our most urgent patients in terms of the cancer patients. What I would say, though, is our other 3 hospitals do very well in the cancer arena. They deliver the standards consistently. They have slight blips, but you're talking small numbers and it only takes a small number to get a bit of variation. But we have seen improvement. We've just got a bit of a long way to go in terms of that 62-day performance for Sheffield teaching hospitals.
In terms of 65 weeks, then the standard, the national ask was to deliver no 65-week waiters by the end of September. We will not meet that standard. We've got a couple of pressure areas across the system. Children's will have about 40 patients who are super complex and they haven't got the clinical capacity to deal with those. They're currently trying to work through that, but I think we'll end on about 40 patients. In terms of Sheffield teaching, we have a very specific problem in neuro services where we are trying to increase the capacity for outpatients, but I think we'll end up somewhere between 200 to 300 patients that will not achieve that standards. And then we've got a specific issue in ENT in Doncaster, predominantly around one surgeon who is super specialist and a backlog of cases there, but a general pressure point in our ENT services in Doncaster. If I'm being honest, I think we could have addressed the ENT issue in Doncaster and we could have moved it around the system earlier. I think there was a desire for the hospital to hold the problem and said they could deal with it. And a learning point for me, certainly, for taking that verbal assurance when the numbers suggested that actually within South Yorkshire we could have addressed the issue. So again, bit of learning for me and a bit going forward and how we address that. In terms of GPs, we've already picked up the collective action. That is the one big thing that is concerning in terms of primary care. And then moving on to mental health services, two real pressure areas there that we're currently working on. One is the out of area placements for patients. That we've seen an uptick and certainly in our Sheffield, the community services and in RDAT, where there's specific work going on to see how we can relocate those patients back into the Sheffield bed base. And the other big bit in the mental health arena is around our ACHD and our neurodiversity, where there is now an operational group working to see how we actually resolve that across the system. That's not going to be a short-term fix. So that is an underlying problem where we've got to look radically at how we're providing our pathways for our ACHD patients and our autism patients, springing from children to get that diagnostics. So those are the big operational issues we've been dealing with in the last 2 months since the board report. I'll pause there and take any questions before handing over, if that's all right. Happy to take.
Lucy.
Thank you. I wanted to ask about mental health and the out of area placement. So we hear about this repeatedly, and it is disappointing to hear that it's gone in the wrong direction. I don't really have a sense, and I'm sorry if I've maybe missed a conversation, but I don't really have a sense that as a board we've really discussed the kind of plans across the patch for dealing with this. There's some kind of reference to places, sort of individual plans at place and so on. But actually collectively it feels as though there must surely be an action that needs to be taken across South Yorkshire to tackle this, because it is something which is a massive detriment to people's lives. And yeah, I'm not really clear what we're doing to tackle it.
There are place plans, but there is also, in terms of the mental health collaborative, are working across the system led by Wendy Lowther in terms of how are we going to address that, looking at our capacity in our bed base and how we relocate them. But I can take that away as an action and bring something back next time is probably the right response to that question, because it is complex in its extreme.
Mark as well.
Yeah, I'll come back to it. Lucy, I think it's a really good point.
Yeah.
So we will I think it's worthwhile Wendy coming back and reporting on the work that is going on. It's a fair point that I don't think it's focused enough or visible enough, maybe a better way here. And it's an issue at two levels. Bloody awful experience, and it's costing us ridiculous amounts of money. If we could get this right, it would make a real difference. Yeah. Mark.
Yeah, it was just to give a little bit more context around what's happening, if you've got a minute or so. But yeah, I think it's the biggest opportunity actually we've got as a mental health collaborative to make a difference, both to quality and finance. So in terms of, I guess, our action plans of how we can tackle the financial problem, but it's got a far bigger quality challenge as well. It's our number one scheme basically. So between RDAS, Sheffield Health and Social Care, and ourselves in Swift, we've got representatives from each organisation looking at how we can learn from each other. What I will say is it's a different starting base and different models operating in each place. So it isn't just dependent on the number of beds you've got, although the number of beds is a key issue. But have we got the right community model? Have we got the right discharge processes and enabling specialist placements to take place? So it's quite an all-encompassing topic, which is certainly something we can discuss, I think, suggested at a future meeting.
Kevin.
Thanks, Chair. Thanks, Sarah, and forgive me, Sarah, if I've misunderstood what you've said, but I think with the very first point around starting to discuss tolerance levels for timings around ambulance handover and reference to the London model. Now, speaking as a layperson, if I've understood that correctly, that feels as though it's fraught with very complex issues around not only the safety of the individual patients who may be being handed over to a potentially unsafe A&E department versus the safety of the patient who's not been able to be picked up because the ambulance is locked up in a queue. So do we have any insight as to what systems, what clinical systems and risk systems and judgment systems will be put in place to ensure that if we do adopt that model, such decisions are really clinically sensitive to the individual that's potentially being handed over within a time scale? It just feels very fraught with individual patient safety issues.
Yeah, that's so in response to that, what I would say that absolutely there are protocols and escalation, and we have what we call the Jeep in terms of our own our way of working with our ambulance service. I think the counter to it is that London have implemented this very successfully across the patch. They've seen a significant number of more ambulances on the road, and they have you will obviously put significant monitoring in terms of escalation, in terms of incident reporting, in terms of clinical review. You would not do something to just shift the problem. You need to solve the problem, and it's complex, but there are ways and means of which you can alleviate the pressures within the ED department. So one of the things that the hospital, if you take Sheffield, a full capacity protocol where you actually cascade the risk and move the appropriate patients through the hospital to alleviate the pressure on ED, but allowing you to then take that that ambulance handover. That has been implemented in some instances in Sheffield. It's not consistent yet, so embedding that process will then allow, you know, the 45-minute handover delays. But we're seeing patients stacking up in ambulance queues for over an hour and a half, which is not doing them any favours either. So this is all about balance of risk, being the safest, recognising that some of it might not be ideal, but there's something about being safe and balancing risk through this whole process, which is part of the conversation we will have.
Yeah, thank you,
I've
Sarah.
got Ian and David. Ian.
Thanks, Chair. It was just to add to Sarah's covered a couple of my points, Kevin, but we did have this debate last winter in the Sheffield place around 45-minute handover policy, and we agreed that we would move to an implementation of that policy. How well that's been embedded through the back part of last winter is the challenge, and we're reviewing that as part of our winter plan. One of the things I would say, Kevin, the dialogue in the Sheffield place was a challenging one, but it was around risk, and it came on the back of where does the risk lie in the system at any one point. It also brought to mind some of the dialogue that we've been having at the South Yorkshire Urgent Emergency Care Board at the time around some very challenging to read coroner's reports that we'd received into the South Yorkshire system around people not getting ambulance in time in the wider system. So I think it's where the balance of risk is, and we chose that at that point it was the right thing to do. How we embedded it is the challenge for this winter, and obviously a wider South Yorkshire dialogue across other partners. I just thought I'd add that. Thank you.
Thanks, Ian. That's helpful. David and then Cassie.
So without rehearsing our UEC Alliance Board, which we're going to go into further detail in this, I think as Ian has highlighted over the last 2 winters, I think we've become more aware of risk doesn't sit within one patient, one department or one hospital. The risk is spread across all of our community. The 2 biggest risks, though, that evidence has shown is that patients who remain in hospital when they don't need to be there are at significant risk of deterioration and deconditioning. So that's one aspect. And at the moment, there are surge times where people in the community can't get the ambulance they require. So independent of risks that will be seen by the professional looking after that individual patient, that is well evidenced. So I think, you know, as I say, we've got plans and we've agendaed it to be discussed further at the UEC Alliance Board, the next meeting and probably the subsequent one. I think where our performance is challenged, it becomes more of a prescriptive approach from, you know, the region and the national team. So that's what's driving this, because last winter we came up with a emergency clear policy, which was a bit more sensitive to, is there a patient actually waiting? Yes, we need to release that ambulance because we know somebody in a Cat 1 needs to be responded to. This is a little bit more of a blunt tool, but actually the reason why it's come about still holds true. Somebody stuck in an ambulance or somebody not being able to be responded by an ambulance is potentially going to come to harm.
Yeah, I wanted to go back round and pick up Kevin's point, I think, which I don't think anybody's really articulated an answer to. So we're talking about balance of risk. We're talking about kind of clearing the AD departments. What we've not talked about is how we monitor harm against any of those pathway changes or any of those potential improvement approaches. So at some point, I'd like us to have a bit of a conversation about that. And I know I emailed Sarah and David before I went off on leave, just around that. And actually, we rely on our individual organisations to give us assurance around harm and safety. And I'm not sure they necessarily always then see that with a fresh pair of eyes. So I think it's something we need to. I think that's what the question Kevin was asking was around how we monitoring harm and how do we know whether those interventions are causing harm. It's not just about who's carrying the greatest risk.
Yeah, and Kathy, you're absolutely right, and as is Kevin, and I think there is data out there which we can evidence the harm in all of the different situations. So I think we need to use that and use that intelligently and balance it. None of this is ideal, is it? Full hospitals are not ideal, so it's about how we balance the risk and how we minimise the harm. But your point is absolutely valid. Yeah, so if I hand over to Christine now in terms of the.
Thanks, Chair. If I just go through a few elements of the workforce report, which is ever changing, and I think the next report will include staff in post and against plan. So what you'll notice in here, it just talks about actuals. It doesn't say where we are against plan. And I think we might come back to that in some of the financial discussion, because the assurance framework around the workforce isn't as rigorous, I think, as what Sarah's been able to describe for other areas of plans. So just in terms of the substantive workforce, though, from April to May, so that's the time period for this data, the current workforce held around 40,000, which is 101% of plan. But when you add into that the number of bank workers and agency workers, that takes up to 4,270. So you can actually see how many workers we actually need to operate our services, which is quite a lot more than our substantive workforce at this moment in time. Sickness absence is quite high at the moment, so it's staying around 5.6%, which compared to other ICSs is actually quite high. And just to put that into context, that is over 2,000 whole-time equivalent workers. So you can sort of see the corresponding nature between sickness absence and agency and bank usage. We unfortunately don't have vacancy information in here as well at the moment for some reason in terms of the reporting. So just in terms of the temporary workforce, we are, as I've just described, using quite high levels of agency and bank usage. And at the moment, that is running at around 2.2% of the total wage bill. And our target for that is 1.3%. So you can see that we have a lot of work to do. And unsurprisingly, that is an area of focus for us in our drivers of deficit work. It's just to look at the root causes of some of that contingent spend, but also the costs of that. So where are those costs lying, and what can we do about that? So I think I'll leave it there, actually, unless there's any questions on that. So
can I just pick up a question, Christine, which is, for me, the weakness in that is we look at agency and bank. I think there's a fundamental difference because of cost. And if our agency was falling but bank rising, I'd be comfortable that we're getting lower unit costs. So there's something there, but it might be difficult. Can we split them out? Because I see a fundamental difference in bank and agency just because of the different cost, which is, I don't know what it is, but it used to be about 20% different cost, something like that. So just for the future, that might be helpful.
If I could just respond, Chair, that it is split out in terms of the numbers. And I think at the end of last year, we did report a shift in the proportions. So I think we moved from about 80% agency. We moved it to more bank, sorry. So we had a better use of bank rather than agency, and we've reduced that. The cost and the demand, though, didn't shift. So the demand didn't shift. So we're not moving the demand for contingent workforce. We've reduced the cost of it slightly by reducing the agency and making better use of bank. So we are reporting that differently. So.
Yeah, I was just going to apologise first up because this will have a bigger section in next month. We are working closely with Kathy's team around having some quality because it's missing out of this report in terms of that.
I've just got an additional one, if I may bring it up at this stage. So we talked about winter. I know we shouldn't be talking about that at the beginning of September, but it is important. But the NHS had a landmark moment this week with the introduction of the RSV vaccination, respiratory syncytial virus. And I actually had the opportunity to administer my first dose to a 75-year-old on Monday. So the target is aimed at pregnant ladies, because if ladies who are pregnant receive the vaccine, the children are then protected in early part of life. Respiratory syncytial virus has a significant impact on a bronchiolitis illness and hospitalisation. So I really want to raise that and promote that. As well as that, it also affects elderly people. So 75 to 79-year-old are also included in the rollout. So that's the here and now. The flu vaccinations, and Anthony leads on the vaccinations, has been delayed until the beginning of October. That's because we want to get full coverage through the winter. So people will be expected to be invited. Public will be invited for that. And of course, the COVID boosters for those identified groups. So I think it's not in the report. I think it's important that we do sort of capture those changes. Thank you.
Yeah, and just a couple of elements in relation to maternity and also quality. So I think just kind of picking up David's point around the vaccination, obviously the LMNS are strongly supporting that approach in relation to that kind of public protection campaign and working with our organisations to make sure that we can vaccinate women at point of access and where it's easiest for them to access that. I think particularly taking into account some of the conversations we've already had this morning in relation to where people prefer to access services depending on the communities that that they reside in. Comment on the kind of data and metrics for maternity. We kind of do need to bottom making sure we've got this timely local data included in the report, because the data that we're looking at is 2 years out of date. Now that's nationally validated data, but we do have local data sets from our trust that feed into a regional scorecard. So we kind of need to bottom that and make sure that we've got that as part of this reporting process, because it's critical in relation to learning and understanding where our organisations are saying that, and just caveating that as part of the review processes that we undertake within our organisations and across the system using the PMRT tool, which is the perinatal mortality review tool. We do take immediate learning out of all of those, and I think whilst there's been a lot of focus nationally on interventions in maternity units, we know the biggest impact that we will make in relation to reducing some of the challenges that certainly we experience is through the equity planning, getting into our communities, and it kind of gets back into that sort of population health stuff and making changes and working with families and women in relation to that. And I think for me some really kind of good news in relation to the sort of vacancy work and the award that we're up for from an ICB ICS perspective in relation to pooled recruitment, that this year we should have filled all of our maternity vacancies, all of our midwifery vacancies, which is, I think, amazing, and due to the work of the LMNS and our providers working collectively together to do that. And it means we're offering posts for all of the midwives that are trained in South Yorkshire. So that will only have a knock-on effect from a safety and a quality perspective as we go and roll forward. So really proud of all the teams across South Yorkshire in relation to that work. And just to kind of pick up briefly in relation to quality, Sarah's already talked about the fact that we've been working both with the DDAT team but also Sarah's team in relation to kind of what indicators do we bring through to board. There are multiple indicators around quality and safety. Each of the places have been looking at different indicators. We're trying to develop consistency and approach across all of the places, and that will then support that conduit up into board and what we actually need to bring here. We had a development session with QIPI in relation to the National Patient Safety Strategy and the work that we've been doing internally as an ICB in relation to quality oversight. So we're kind of getting on that journey in relation to kind of what we will bring through, what's useful, and actually what needs to come through to QIPI and what doesn't from an assurance perspective. National Patient Safety Strategy is being reviewed. So we are working with our collaborative, SpecCom and our providers in relation to what does that mean? What does that mean in relation to the changing face around commissioning of services, and what will quality oversight and assurance look like for us as a system going forwards on the back of that? I always talk about lots of players being on the pitch, particularly in relation to MHLDA particularly. There's a lot of players on the pitch, and how do we make sure that we've got that focus on quality improvement? And the last thing I just wanted to mention, which I think links into quite a lot of the things that have been raised through the place reports, but also in relation to urgent and emergency care, and also Martha's Law rollout, which I'm sure lots of people around the table would have been familiar with the comms around that from a national point of view, is the peer framework which is being developed nationally. So that that acronym is around prevention, identification, escalation and response to physical deterioration of individuals across the system. So whether that's kind of linked into UEC from emergency waits, virtual ward approach, care homes, MHLDA, there's a kind of framework and approach being developed nationally what will be expected to look at from a system point of view, and where our role as system convener is in that, but also making sure that we don't step onto the toes of the processes that we've already got in place. So we'll bring more back to to QIPI and to the board on that as that evolves.
Thanks, Kat. That's really important. Thank you. That's really important work. Leslie.
Thanks, Piers. Just a couple of things really. Sarah, this report's looking loads better from my point of view. There's real meat in this now, and it feels accessible. So I just wanted to say that because I think it's important. But I was about in sorry. Some narrative, a lot of acronyms and things that are not really explained. And I think, you know, this is a public facing document. Yes. We ought to just make sure we've got a glossary or just the bracket stuff, just so we make sure that people understand what we're talking about. So that's just kind of practical point. I suppose I just reflecting reading this yesterday about some of the underlying things that are here though about inequalities. And particularly inequalities of access, I think, were in my mind as I was reading things. So I was looking at for example, the dementia diagnosis rate, and actually if you just read the headline, then we're doing fine. When you look and you drill down to place, then some places are doing miles better than others. And so if you live in one part of our patch, you're not going to do as well as if you live somewhere else. And I think we really need to try and understand some of that. Because you know it can have implications for outcomes as well. It's not just about access, but about outcomes if you're not getting picked up early on dementia, for example. And I noticed the health checks for LD for learning disability as well. You know, some quite stark contrasts sometimes, and I just think we need to understand that bit as well as the headline that we're doing fine. So it's just an observation, really.
So
Yes, I just really commend Leslie's point. I mean, one of the reasons why we put that information into the report, we're presenting performance information with a kind of, whether that's deprivation or ethnicity or by place, is to prompt exactly that discussion. So I think we've probably got to get more active about how do we use that information in the report to have a debate about, well, why is it different for that part of the community? But there's some really fascinating stuff. I mean, if you look at winter, for example, and demand on ED, there's a real difference in terms of deprivation, and that links to the conversation we we're having at the beginning of the day, which is about actually where do we focus our efforts to, because that's a consequence of part of the community being poorly served. So actually, what could we do to serve that community in a different way that actually helps us with some of our challenge?
Thank you. Anything else on that? Thank you. Really helpful, that, Sarah. Corporate assurance report, Mark.
Thanks, Chair. I'll take the report as read, but I do, and I will, run us through a number of sections that I would like to highlight. So in terms of the report itself, I'll take that as read, but I do want to highlight that it sets out some really significant work that's undertaken across the organisation around corporate activities. Also attached, Appendix A is a summary or a précis of the main business items transacted in the subcommittees of the board. So that also is presented to the board just for information, confirmation, and to add to its assurance piece. In terms of the board assurance framework and the corporate risk register, at Appendix B, an executive summary is presented of our key risks. Work continues to refresh the board assurance framework in the context of our 5-year forward plan. I would highlight that if, you know, and I'm sure the board members of the board have reviewed and scrutinised the BAF Appendix B. The key risks that are highlighted in terms of the BAF, which relate to the DRI estate and the delivery of the financial environment and transformation, is also echoed in our corporate risk register in the highest risks related to the delivery of transformation programs at place, which is also reflected in the issues log where the significant challenges to the Doncaster Royal Infirmary estate are our most severe issue. And then finally, I'd highlight at the Appendix C, a procedure which has been approved by the executive, which is around the procedure for the control of contractors, which is just some essential governance that we have to have in place, and it's presented to the board for ratification.
Thank
you. Pierce, I just noticed on page 33 of the report, IL20, it's in relation to medicines and savings target. It moved from risk to issue, and in the process of that, the format, it hasn't come through. So at the moment, the mitigations actions don't reflect all of the actions there. That's purely administrative thing. We'll get that corrected going forward, but just to assure the board that there are a range of actions that are in place to respond to that issue. Thank you.
David, thank you. Okay with that? Thank you, Mark. Thank you. ICB constitution and governance changes. Some of these followed the recent staff changes. So do you want to talk us through that?
Yeah, of course. Thanks, Chair. So just following on from from Gavin's Chief Executive report and the changes that are signalled there around the role of the Executive Director of Strategy and Partnerships and the Director of Performance and Delivery, this report summarises the key approvals and next steps in terms of our corporate governance that need to be transacted over the coming months. So it's in a number of parts. It sets out some immediate approvals for the board, but it also sets out a bit of a work programme between now and probably Christmas for us to undertake the necessary housekeeping updates. But just for procedure, I just want to run through a couple of the sections. So in terms of very immediate and specific amendments to the ICB constitution, the board's asked to know and to approve a series of two changes really, and they're set out in section 2.1, and they relate to replacing the Director of Strategy and Partnerships with the Director of Performance and Delivery in the board composition section of the report of the constitution. So that's 2.1 1 and 2.12. So I'll just bring those to the board for approval. The board's also asked in section 2.2 to revise 3 board designated roles. So the executive lead for children and young people, the proposal is to amend to the chief nursing officer. For the accountable emergency officer, subject to the approval of 2.1, is the board's asked to approve a change to the director of performance and delivery, and the board's asked to approve a change of the senior information risk owner to the director of corporate governance and board secretary. As a consequence of a series of changes that are proposed to the scheme of reservation and delegation, which are set out in 2.3, I won't run through all those because they are consistent with the changes that are set out in the 2 paragraphs above. And then in the remaining 2.1 to 2.8, we just set out the rest of the work that needs to be conducted. In section 3, helpfully, one might say, NHS England have also released an updated NHS ICB constitution for us to consider and adopt at our earliest opportunity, and the principal changes in there are signalled within the report, and they are related predominantly to the provider selection regime and some housekeeping changes that are there now to remove the establishment orders that relate to the establishment of the ICB. So in terms of the recommendations to the board, just to repeat, the board's asked to approve the described changes to the ICB constitution, designated roles, and the scheme of reservation and delegation. To note the review work to be undertaken to revise the terms of reference and corporate policies and procedures, of which they are manifest, which is a really significant piece of work in the coming months, and receive in due course a revised constitution that reflects all of the changes that are aforementioned, and note the governance work plan that's described in the paper.
Thank you.
I've tried to do that quickly.
That follows the staff change. Do we know?
The November formal and probably January formals too, dependent on the timeliness to get them through the relevant subcommittees.
Okay, people comfortable with accepting those? You did that remarkably quickly, given the level of detail there. So thank you for that. Emerging preparedness resilience framework. Will.
I want to remind you the paper I mentioned a bit last year,
Yeah.
there was quite a significant change in the approach to the assurance to take on board some of the learning of some significant incidents that happened across the country. What that meant, and I'm just re-emphasising because I think it's important for this year's process. What that meant was our approach to our assessment of all of the 48 standards that there are, in taking on board that learning, meant that there was a perceived reduction in our sort of meeting of all of those standards. I emphasised that doesn't mean that we're any less ready or prepared to respond well in those instances. It was just our approach to being more rigorous in our assessment of those standards. So I just wanted to highlight that. In the paper on page 3, I've set out a summary of the process and the timeline for this year, which has started and will run through towards the end of this year. It will follow the same principles that we applied last year, so that won't change. It will contain an organisational assessment of its compliance. It will also have an element of check and challenge, and of course we'll also confirm that and declare that at our organisational boards. The thing that I highlighted last year as well, which is worthy of noting, is the change that will happen in terms of the ICB's responsibility in relation to other organisations. So as Category 1 responder, we've got the responsibility to coordinate health in relation to incidents, and we've done that quite significantly over the last 2 years. But we also have a responsibility to coordinate and do the assurance of our organisation's own EPRR arrangements as well. So we will now lead that as the Integrated Care Board for South Yorkshire and its NHS providers. So the process that is summarised in the report is the process that will also apply to our providers as well. The final thing I just wanted to highlight is, as with last year, the way that the timelines work along with our board meetings means that we will need to confirm the outcome of the assurance to NHS England before the board actually has the opportunity to ratify that, which would be in January. So there's an ask of the board to support that approach. But I just wanted to remind the board as well that we will be taking all of the outcome of both ours and the systems assurance process to our Audit and Risk Committee. We have updated the Audit and Risk Committee as a committee earlier this year on the plan that we put in place for our own assurance last year, and we did share a more detailed appraisal of where we were at and the approach for this year with our audit and risk members in July. So just that is happening from an internal assurance process. I think my very, very final thing is to thank Sarah and the team, because actually they are doing the work, and I think that fits with the changes that we've just made, and the team does. So just want to say thank you to Sarah and the team for getting us into a really good place, because actually the detail behind this shows I would say some quite significant improvement from where we landed last year. We were 17% compliant overall as an ICB, because we really wanted to apply the learning, and we obviously wanted to continue that approach, but nonetheless, on the face of it, I think that we will be able to show an improving picture, certainly in the ICB and hopefully across the South Yorkshire organisations at our board in January.
Well, thank you. Any points for that? Can I just say that those of you who don't realise, this is Will's last formal board meeting, so technically that was his last agenda item.
Thank you for that.
So I just thought that was worth mentioning. Genuinely, other occasions I will say this: thank you very much for your help and support, both the board meeting and indeed the setting up of the ICB.
It's been a pleasure.
Genuinely, I'm personally very grateful. I know the rest of the board have really valued your input, but this is him saying I've got nothing to do with EPPRR anymore. Isn't that not right?
I do think it's ironic, but that is my last.
Yeah, there is something ironic about that. I agree.
But thank you for the learning opportunity.
It's been a pleasure, Will. He couldn't wait to get rid of it. I think that's fair to say.
Yeah.
But genuinely, Will, thank you very much for your time and effort into the place. Okay, we've got a series of minutes to receive. Anybody want to pick up any issues from that?
Issue, but it's just something that is worthy of mentioning. When I think Lucy talked about perhaps things that we don't see as visible at this board. I'm just mindful that our SLE minutes are in that sort of presentation as well, and it's just a reminder that our system leadership executive, which is the executive bit of our wider governance, probably worthy of us just thinking about the stuff that we want to lift out and bring here, because actually some of certainly the mental health agenda gets an awful lot of time at the SLE agenda, and I just don't know whether there's just something about how we sort of review that and think about what needs to translate across the board.
I think that's a legitimate point. The issue for me is I think Lucy's point, that needs more focus here anyway, the best of time. So how we do that.
So yeah, I think that's absolutely right. Well, I mean, the other thing that I'm conscious of is part of the formal SLE meeting. There's something called a kind of flashcard report, which is basically a report of every single program that's running within the across the system. So it's a really great way of getting an overview of all of the work that's happening. Now I don't know, we don't include it here, which I think is quite right, because it's probably, but we have talked about making that available to board members, so you can access it and at least see, if you're wondering what's going on around learning disability and autism, you can see the latest report, which would update you, at least give you the headlines. Sorry.
Yeah, thanks. I think that's valuable. What I don't want to do is go back to sort of 500 pages of board papers. So
I think it's like a link.
You can access it rather than it's part of the board papers. Would be my thing. Okay, really helpful. Thank you. Anything on the place committees? Anything from the assurance committees and your assurance committee chairs? Okay, meeting dates for next year are appended for there. We do now have a private board session, which is unusual. Can I suggest we take a 15-minute break and we come back at 12:15? And I'm afraid members of the public have to leave us now. Thank you very much. 15-minute break, 12:15 for this. Is that all right, everybody? Thank you. Thank